Today we are going to talk about the pathophysiology of hypertension, ischemic heart disease, and atherosclerosis. Now, these topics uh, are really huge, but I'll try to make it short, although not too short. Firstly, when you call something a myocardial ischemia, we mean a very particular thing. That is, it's a mismatch between supply and demand. When the cardiac demand for oxygenated blood is much higher than the myocardial supply, also known as perfusion, then myocardial ischemia may happen. And this myocardial ischemia can present in several ways. Uh, these specific clinical presentations are collectively known as ischemic heart disease. It mostly includes these four main categories. All of these four categories have their own subcategories, but we will go into that later. The four main categories are myocardial infarction, angina pectoris, chronic ischemic heart disease with heart failure, and sudden cardiac death. And about atherosclerosis, it is actually part of a larger vascular pathology, which is known as arteriosclerosis. The term sclerosis means thick, tough, hard, and arteriosclerosis, which is the parent category here. You can see. Can you see my mouse pointer?
Yes, sir.
Okay. So arteriosclerosis, as you can see, this is the main umbrella category. It means hardening or thickening of arteries. Now, this arteriosclerosis uh, can be subdivided into four classes. One is arteriolosclerosis. Arterioles becomes thick, tough. Monckeberg medial sclerosis. The medial is mostly found in senile changes, like in the myometrium of an atrophic uterus, where the blood vessels have thick walls. Arteries have thick walls and maybe some calcifications within them, etc. So the another category is fibromuscular intimal hyperplasia. This is a reaction pattern. It's some kind of response to injury, one kind of response to injury or growth factor. Uh, but for this lecture, we are going to focus on one specific type of arteriosclerosis, that is atherosclerosis. The term athero, it comes from, well, Latin or Greek, I don't remember at this point. So a root word atheros, and atheros means gruel. It's some kind of a sagu or some liquefied uh, nutritious drink, um, or maybe some thick protein soup. Uh, have you seen and a representative image of it is shown here? So this looks like some semi-solid, thick, some soupy thing, uh, gruel, and if atherosclerotic plaque is sectioned, sometimes you can find this kind of material, gruel-like material. So that is atherosclerosis. So we'll come to that later, what this semi-solid type of disgusting material made up of. We will come to that later. Up to this point, could you get um, what I'm saying? Are there any difficulties or maybe some changes in modes, or please, if you have any suggestion or question at this point? Hmm? Everything's fine? Okay, then let's move on. Now, this is a microscopic image, and also in upper left corner there is a diagram of an atheroma. Atheroma is comes from athero, you know, the gruel-like material, gruelous material, and oma means swelling. So it produces a bulge within the arterial or whatever, the vascular lumen, the arterial lumen. So what does this swelling contains? What are the contents within that swelling or atheroma? So firstly, please notice that this swelling is actually inserted between two normal structures. One is this internal elastic lamina. Can you see this wavy dark line? Can you see here? This wavy dark line is
Yes,
called
sir.
internal elastic lamina. And these single layer cells with a basement membrane, it's called, can anyone tell me? What is this topmost single layer?
Epithelial.
Yeah, vascular endothelium. So normally this vascular endothelium, then basement membrane, then there should be a little bit of connective tissue, and just after that there should be this dark wavy elastic lamina. There should not be something in between. So much things in between these basement membrane and elastic lamina. But in this case, we see there is something accumulated here. So this is our atheromatous plaque we're talking about. So at this point, the plaque contains a necrotic center, which contains some foamy macrophages, fibroblasts, some cholesterol crystals, some leukocytes, and some vascular proliferation here and there, mostly at the two tips, two endpoints, and also some uh, smooth muscle cells will be there. And the center will be necrotic, like the gruel, like, I mean, that kind of sago type food, uh, which I showed a picture in the previous slide. So that gruelous material will be here. This is the gruelous material. The term athero comes from that gruel-like material, semi-solid, disgusting food. So, and the top of it, I mean, towards the luminal side of this necrotic material, necrotic center, this part will be toughened. It will have some fibroblasts, some fibrosis, and also some smooth muscle cells. And sometimes endothelium will remain intact, sometimes it will get ulcerated, but that's a different issue. This part is known as fibrous cap, and below this necrotic center of the atheroma, the other layers of the blood vessels of the artery continues, like the tunica media, tunica adventitia, etc. Microscopically, uh, it looks like this. The corresponding structures are shown microscopically, as you can see. So, could you get the structure of the atheroma? Was there any problem understanding it? Because if you have problem understanding this structure, you will have problems understanding in the subsequent slides. So if you do not understand something here, please notify. Okay. I think everyone understood everything. That's fine.
Yes, sir.
Okay. Now, how does this atheroma is produced? Now, firstly, there has to be some kind of endothelial injury, and that has to be chronic. Acute injury uh, does not instantaneously cause the atheroma. It's a long-term process, maybe years, decades even. It takes a long time to develop atheroma, so that has to be chronic endothelial injury. And how can that be, that injury, where can that injury come from? It can come from a number of factors like hyperlipidemia, hypertension, smoking, homocysteine is another cause. I guess not that much common, but written in the book. That's why I mentioned it. Hemodynamic factors, toxin, viruses, immune reactions, a plethora of things that can injure chronically. Um, Now, what is the next step? Then the endothelial dysfunction will be there. And endothelial dysfunction will cause monocytes to adhere because endothelial dysfunction expresses some proteins like integrins, uh, lectins, etc., which causes monocytes to adhere to endothelium, and also the hemodynamic disturbances. This can also push the leukocytes towards the periphery even more, and accelerating the process of monocyte adhesion and immigration, which is normally happens in where, in what other pathological sequence of events do you see this leukocyte adhesion and immigration? Can anyone tell? In which chapter of general pathology do you come across the term this leukocyte adhesion and immigration? Can anyone tell?
The inflammation.
Exactly. So this is basically a vascular event of inflammation. But please remember that when we say the vascular event of inflammation, we mean that some tissue got injured and blood vessels supplying there. The leukocytes are escaping the blood vessels to get to the site of injury. But interestingly, in this particular case, the injury is perceived to be, in the vessel itself. The vessel is not supplying some injured organ, but the vessel itself is injured. Do you see the point? The vessel as an, if you consider it as an organ, then this vessel is injured. And more interestingly, the injury is not where the leukocytes are immigrating to. The injury is basically the endothelium. But interestingly, our body doesn't know any better. It is programmed. It is programmed by evolution to supply these leukocytes to the site of injury. And the only way it knows how to do that is to make those leukocytes cross the endothelial layer and go beyond that. So this is the only way it can respond. Uh, it's a stereotypical inflammatory response. It's seen across all the mammals and also in some warm-blooded vertebrates. It's a evolutionary conserved mechanism. That's why, although there is no particular injury to the tunica media or beyond the endothelial layer, although there is no real injury there, the leukocytes are going to go there because they do not know anything else. They only know that if there is some injury, the endothelial, if it permits to move across the barrier, endothelial barrier, they have to go the layer beneath. This is the only thing they know, and that's what they're doing. Although the injury is on the endothelium itself, not uh, 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 in the layer beneath. This is a very interesting and important point. Tell me if you do not understand what I just explained. Anyone? So you all understood this concept? Well, you're very brilliant people. This concept took me a while to grasp, but you could understand it just like that. Thank you. Now, the thing is that I always wondered why on earth these leukocytes are, are crossing the endothelial barrier and going underneath, because there is no injury underneath. The injury is in the endothelium itself. So why are they going away from there? Uh, and then I learned the thing is that the leukocyte adhesion and immigration is the only way body knows how to respond to a threat, whether there is anything there or not. So that's what it's doing. Just recapitulating the inflammation here. But in turn, it will cause the main problem. If the leukocyte stayed on the endothelial surface, did its repairing or everything, then we would not have this atheroma in the first place. Now, what does endothelial dysfunction entails? So it can come from it can occur from hemodynamic disturbances, hypercholesterolemia, and of course the inflammation we just were talking about. And these causes what? These causes increased permeability, leukocyte adhesion, and when leukocyte adheres, at some point it's going to immigrate because that's the typical molecular sequence. Once started, it has to be complete. It has to complete. It can stop. It cannot stop midway. If it immigrates, then it will. If it adheres, the leukocyte adheres, then it will immigrate. And in this case, the neutrophils are not adhering. Monocytes are adhering here, but it's actually the same mechanism: the leukocyte adhesion and immigration. So this point is has got a little bit of thing going on around, and you see the platelets coming around because the endothelial surface is exposed. The platelets are attracted to the negative charges, and also some platelet attractant factors are being released here because the body thinks that a blood vessel is injured, maybe there's bleeding, so it's trying to make a platelet plaque as it would do in normal hemostasis. But in this case, there is no such thing. There's no bleeding, but the body doesn't know anything else, so it does what it always do, and this will create a problem. So up to this point, is the thing clear to everyone?
Yes, sir.
Okay, thank you. After that, a cascade of event follows, like smooth muscle cells, they will also join the party. Now, some of the smooth muscle cells will come from the tunica media layer, immigrate from there, and some of the smooth muscle cells will be transformed. It's called transdifferentiation, transformed from the mononuclear cells that comes from the blood. It's very interesting because in blood, which cells do we really have in blood? Do you have smooth muscle cells circulating in blood? Do we? What do you think?
No, sir.
Yes, sir.
Exactly. But we do have some mononuclear cells like monocytes, and some of those monocytes has got the potential to turn itself into these smooth muscle cells given the proper signaling. So in this case, the inflammation creates an environment where the migrated monocytes from the blood, not all of them, but those which has still retained the capability to express the contractile proteins and such. So they, upon getting the trigger, they will become from monocyte to smooth muscle cells. Also, some of the smooth muscle cells migrates from tunica media. Once it was thought that the source of smooth muscle cells within the atheroma center, it solely comes from the tunica media. But later it is found that a good proportion of those smooth muscle cells also comes directly from blood in the form of monocyte and then gets transdifferentiated. So can anybody tell me the difference between transdifferentiation and metaplasia? What is metaplasia? Can anyone tell me?
Metaplasia is a disordered growth.
No, not dysplasia, metaplasia. Anyone?
So
Abnormal proliferation.
transformation of one adult cell type to another adult cell type.
Okay, so there is a little bit of revision that has to be done there. Transformation of one adult cell type to another adult cell type is transdifferentiation. Uh, that's different from metaplasia. Uh, in metaplasia, one cell type is replaced by another cell type. The term replaced is applicable for metaplasia, which is not applicable here. So what is replaced means, suppose you have got epithelium. Can anyone give me an example of common example of metaplasia? Anyone?
Squamous cell carcinoma.
Squamous cell carcinoma is a carcinoma because it's not metaplasia. Even if it was, it has passed the point. So can anyone else give an example of metaplasia, not carcinoma, not anything else, just metaplasia?
So Barrett esophagus.
Exactly. So what happens in Barrett esophagus? Somebody didn't have a Barrett esophagus and somebody developed Barrett esophagus. What's the difference between the lining epitheliums? Can you tell me?
So squamous epithelium is transformed into columnar epithelium.
Okay, so this word transformed is not applicable here anymore because
Sorry,
research
sorry.
shows
It's
research
replaced.
uh, research shows that the the squamous epithelium that was present in the lower esophageal part, uh, those cells do not transform into columnar cells. Those cells get shedded as a normal cellular turnover, but the new cell that forms from the stem cells, they do not become squamous cell. The new epithelialization takes place in the form of columnar epithelium. So this that's why it's called replaced. Uh, do you get my point?
Yes, sir.
So in metaplasia, the actual cells do not get transformed. They die, they shed off, they are out of the picture. The new cells that comes, emerges, develops from the stem cells, they become the other type of cell. So this is technically, it's not a transformation. It's a generation is gone, dead, withered away. The new generation is not like like the previous generation. They look different. So this is metaplasia. Okay. Now, but in case of transdifferentiation, there is transformation. That means stem cells have nothing to do with it. The adult cell themselves transform into one another. It's like you met a friend in your childhood, then a long time no see, then you meet him or her again, and you find that he or she is completely changed. It's something like that. It doesn't involve a new generation. The same person became somebody else. That is transdifferentiation. So do you get the point? Huh? Now,
Yes, sir.
okay.
Yes, sir.
So here these smooth muscle cells, they are transdifferentiated from the mononuclear. Some of the mononuclear cells who express the uh, right kind of proteins, etc. So they immigrate from the circulation into the layer beyond the endothelium, and then gives the inflammatory signal, and they themselves get transformed into smooth muscle cells. So this is the thing I was pointing to, and new uh, methods, new immunophenotyping methods are being developed to identify if there is an increased circulation and increased circulation of these mononuclear cells, which has the capacity to transform into smooth muscle cells. It varies from person to person. Those who have a higher number of those kind of cells could be at greater risk of developing this atherosclerosis. So identifying from those cells from the from the circulation is could be an important biomarker to predict the risk of developing atherosclerosis. Works have been being done on that thing. That's why this is important. That's why I mentioned this, because this is one of the direction the research is going. Now, the the after that, the macrophages and smooth muscle cells, they engulf lipids, and sometimes they make some of their own lipids, but they cannot degrade it anymore. So this is basically a metabolic rearrangement. Uh, so, and sometimes if there is high level of circulating cholesterol like LDLs, and this can also contribute to this lipid accumulation process. So uh, this, these lipids will cause some changes that are visible to the naked eye. As you can see, the fatty streaks being developed here, and this is an actual photograph of from a large vessels that have that is in the process of developing atherosclerosis, and we see a fatty streak here. The reddish or orangish area, this is how it's supposed to be, the endothelium, and it should look like this pinkish reddish area, not this yellowish linear area. This is the fatty streak that develop as part of the pathogenesis of atherosclerotic process. So where does this lipid come from? Can anyone tell me? I just mentioned. Anyone? Where does these lipids come from? Okay, then I'll continue. If you choose to remain silent, you have the right to do so, but I must continue. This is T lymphocytes. They also play a very important regulatory role here, because basically this is an inflammation that's gone awry. Now, the smooth muscle proliferation, collagen, and other extracellular matrix deposition, and some accumulation of extracellular fluid, all these make the thing, the atheroma. Now we have got our atherosclerosis, full-blown atherosclerosis. And now that surface is no longer a fatty streak or a yellow line something. It's really visible, sometimes palpable. If you cut down the, blood vessel, you can palpate it inside the blood vessel, that it's bulging out, and it feels fibrofatty, like soft to firm, and unless and if it's calcified, then it will feel hard. But before that, it's firm to hard. Soft to firm, and some and all the structures you expect in an atheroma eventually develops in this way. It can take decades. Now, here are the specifics, specific things that we have discussed. All the points are shown in a single diagram. When I share this section with you, we can go through it very minutely. I'm just going to skip this for now. All these things are covered already. Now, what are the major risk factors for atherosclerosis? So there can be some modifiable and non-modifiable risk factors. Can anyone tell me why the increasing age happens to be a major risk factor? What is the connection between aging and developing atherosclerosis? What's the mechanism that connects an elderly people susceptibility to develop atherosclerosis? Can anyone just throw a wild guess? No problem. It's okay to make mistakes. Anyone?
Sir, aging এর জন্য free radicals.
Good, very good. This is one of the really contributing factors related to aging. Anything else? Well, the thing is that throughout the whole conversation, we say that atherosclerosis is a process that takes a long, long time to develop. It's a lot of steps, and every step needs a bit of a time to go to the next stage of development of the atherosclerosis. So it's not overnight process. So the older a person is, the longer the atherosclerosis had time to develop. Okay? Do you get the point?
Yes, sir.
Okay.
Yes.
Clear? Okay.
Yes, sir.
Now, male gender. Can anyone care to explain why male more susceptible? Anyone? Well, it's fine if you do not know, because I do not know either. Scientists are looking for it. Why males are more susceptible for this? They do not still have any clear understanding. Some hypotheses here and there, but nothing much definitive. If you can discover something, you can report to the Nobel Committee. Okay?
স্যার
Yes, sir.
ইস্ট্রোজেন ডেফিসিয়েন্সি মানে ফিমেলদের যেটা থাকে ইস্ট্রোজেনের কারণে
Well, that's one of the hypotheses in the list of hypotheses. Yes, it's a possible cause, but nobody really knows the in between steps. Low estrogen leads to what? Leads to what? Leads to what? leads to atherosclerosis. What are these what's? Okay, so there are some missing information there. But we do know that males are more susceptible to develop atherosclerosis than females. Every other things are being matched. Every other things being equal, male and the female, the male will develop, will most likely develop atherosclerosis. The female will not, or maybe if the female develops, it will develop it later. Is it related to hormone? Maybe. Is it related to something that they have in X chromosome but not in Y chromosome? Maybe not related to sex determination. You know, X chromosome has got many more genes other than sex determination. So uh, the females have got something that is activated. I don't know. Right now, it's some wild guesses. So uh, and the modifiable risk factors, we do have some clear understanding how this could contribute, like hyperlipidemia. This will supply the lipids, I mean, the smooth muscle cells and the monocytes, macrophages, they engulf lipids. So this lipid has to come from somewhere. They have to, either they have to be metabolic result of metabolic disturbances being created de novo inside those cells, or it has to come from circulation. So the people with hyperlipidemia, they will have high levels of LDL, and that will supply the lipids to develop the atherosclerosis plaque. So this is a reasonable explanation. Hypertension, it will cause hemodynamic disturbances and cause endothelial injury. So you can understand cigarette smoking has got a many components which can injure endothelium. It's been shown with almost certainty. It's experimentally proven that cigarette smoking causes endothelial damage. And diabetes has got a plethora of metabolic changes, and that also includes atherosclerosis. Mechanisms are pretty well defined in this case as well. And inflammation, and of course inflammation. We have already discussed about this. Now, the consequences of atherosclerotic diseases. So, atherosclerotic diseases can lead to many kind of diseases, problems, but we will, in clinical settings, these four type of things are the most relevant. One is myocardial infarction, cerebral infarcts, aortic aneurysms, and peripheral vascular diseases. Like Burgess disease, for example. It can Burgess disease, for example. So, can Burgess disease be? I just said Burgess disease. Was it a correct example or an incorrect example? Can anyone say? Anyone?
It's a correct example.
Um, well,
Diabetes থেকে
Burgess disease is not related to diabetes. It's related to smoking. Male,
sorry, yes.
more than 55 years, has got digital progressing gangrene, sometimes claudication pains are the early signs of these. I'm talking about that disease. Is it related to atherosclerosis? Can anyone tell? Okay, this is the thing. I think you should you can take it as a task. I mean, a kind of your optional homework to find it out yourself. It's interesting. So let's keep that for now. Now, the atherosclerotic involvement. Can anyone tell me that what is the most commonly involved vascular site of atherosclerosis? Where the atherosclerosis is most likely to, most commonly forms? Can anyone tell me? Anyone?
Coronary arteries.
Thank you for your thought. I appreciate answer even if it's not, even it's okay to make mistakes. And the interesting thing is the coronary arteries comes in the second or third place. The most common place for atherosclerotic involvement is the lower abdominal aorta and the iliac arteries. So sometimes lower abdominal aorta, they rank first, iliac arteries, they rank second. Sometimes iliac arteries come first and lower abdominal aorta comes second, but coronary arteries is most definitely not the champion here, merely got a bronze medal. Okay? Huh?
Yes, sir.
Okay. But the thing is that the atherosclerotic involvements in lower abdominal aorta and iliac arteries, they are very high caliber vessels, and they have got some collateral supplies and some other measures that prevent the clinical manifestations to develop early. So although they are the most common sites for atherosclerotic involvement, they are not the most clinically relevant places. Did I make myself clear?
Yes, sir.
Okay. Now, although the coronary artery comes, third in the competition, it creates the most fuss. So you can see the list here. It's most involvement to the least involvement. It's arranged in this way. Now, how does it happen? The laminar flow, it causes the flow chart in the right hand side is actually what physiological conditions should have. Are you familiar with the laminar flow and what's the opposite term for it? Anyone?
Turbulent flow.
Please be louder. Be proud to make your own mistakes. Otherwise, how will you learn? Please be louder. You did not make mistakes.
Turbulent flow, maybe.
Turbulent flow. Good, good, good. You should not be. You should not be afraid to tell what you think, even if it's wrong. But in this case, you are right. You were not wrong. But still, you should be confident. Now, can anyone tell me what's the difference between laminar flow and turbulent flow? Can anyone? Just step in, participate, and try to make this session, this virtual session where I cannot see any of you. You cannot see me. I'm trying to make it a little bit more interesting and try to make sure that you do not forget these things easily. So please help me.
So laminar flow is a static transient flow in a one direction.
Okay, so lamina. Do you know the meaning of lamina? Forget about the flow. Can anyone tell me the meaning of the word lamina?
Lamina lumen.
No, lamina means layer. Lamina propria. Lamination. Did anyone have seen how they laminate a document? Maybe you laminated your BMJC registration certificate or MBBS certificate from a local.
Yes, sir.
Huh?
Yes, sir.
Lamination. So lamination means layer. There are two layers, one above, one below. That is lamination. Okay. And the layers are parallel, right? Parallel. Now, in laminar flow, the blood flows in such a way, or any fluid for that matter, not just blood. So, for any laminar flow, any fluid that flows, it's like a layered in a layered fashion. There is a layer of molecules of that fluid goes to the same direction, and just above and below, those molecules are just in parallel compared to the central layer, and it looks like a parallel sheets of molecules are moving in the same direction. This kind of flow is called laminar flow. Did I make myself clear?
Yes, sir. Yes.
Okay. Now, when this parallel, and what are they parallel to? They are parallel to the vessel wall. All the molecules in the flow are parallel to the vessel wall, and they are moving like in layers. So layer means lamina and parallel layers. So laminar flow. So do you understand this thing now?
Yes, sir.
Okay.
Yes, sir.
Now, whenever these flow, the molecules within the flow are not flowing in any discrete lamina. I mean, they are flowing, but they are not really molecules, and the groups of molecules are not really flowing parallel to the vessel wall. They're not creating any particular parallel layers. So that is the turbulent flow. Okay.
Yes, sir.
Now these laminar flow, uh, uh, will it have more friction with the vessel wall or less friction?
Laminar flow, less friction.
Okay, less friction. Well, I use the term friction here, but if there was any people from the physics department, I hope not. Everyone is medical student here, right?
Yes, sir.
So someone please please mute yourself if you're talking to phone or something, please. So, uh, well, if there was any, we have got medical students here, but if there's a physics student here, he or she would object that no, in case of fluids, we do not use the term friction. It's called viscosity. Okay, viscosity is nothing, just a kind of equivalent to friction in case of fluids. Friction is for solid objects. Okay, so
Yes,
the
sir.
laminar
Yes,
flow.
sir.
Okay, so does the laminar flow has the higher viscosity, or the turbulent flow has got higher viscosity?
Turbulent flow.
Exactly. So that means which flow creates more force, creates more pressure or force on the vessel wall? Laminar flow or
Turbulent.
turbulent flow? So these endothelial cells, they have got receptors, mechanoreceptors. They can sense pressure. They can sense force. They have got proteins like that. So whenever the flow is laminar and there is not much pressure there beyond the threshold, uh, the Kruppel-like factor 2, KFL2, is activated. It remains activated if the flow is laminar, and it ensures that no atherosclerosis develops within the vessel. Okay, so this is all the things. The atheroprotective genes are on, the inflammatory genes are off, etc. But ultimately leads to no atherosclerosis. So do you get the point here?
Yes, sir.
Okay. Now let's see what happens if the flow is turbulent. See, now the turbulent flow, it causes more pressure, or mechanoreceptors get activated, which inactivates the KLF2, and it is atherosclerosis. Okay.
Yes, sir.
So do you think there are some therapeutic targets that targets KLF2 would prevent atherosclerosis? That would prevent inactivation of KLF2? If there is some drug that can
Statin group of drugs.
exactly, the statins can do that. Thank you. Somebody has read the book. I appreciate that. Now, the plaques do not occur randomly. Okay, so they depend on a lot of factors, like the ostia of exiting vessels, so blood. It's like a bifurcation, like branch points. I mean, uh, along the and also along the posterior abdominal aorta. Is the abdominal aorta is a completely linear vertical structure, or is it a little bit curved? Can anyone say that? The abdominal aorta.
Linear.
I'm afraid not. Thank you. Thank you for asking. Yes, it got a bit of curvature, and in at least two axes. So you go to the anatomy books. It's always good thing to go to the basic science books. It gives you perspective, clinical perspective. So please go there. So these abdominal aorta, it's got a bit of curvature, right? So that's the reason behind, and it has got a high volume, high flow uh, vessel. So this is an important contributing factor that why it's a champion, or I mean, runners up in the race of developing atherosclerosis, the abdominal aorta. Okay. and
Yes,
it has got a lot of ostia. I mean, lot of branching points. The abdominal, how many branches are there in abdominal aorta? Can you tell me?
So celiac trunk, superior mesenteric branch.
You list all that. Okay. Okay. I'll save you. I'll save you the list. It's actually the 13, and branches are there. Okay. Count them all. Now, this is the reason why abdominal aorta became the champion or runners-up. Okay, in the atherosclerotic involvement. Do you understand now? Huh?
Yes, sir.
Okay. Now the flow patterns are disturbed and non-linear. So this is the mechanism. And as a student of nuclear medicine, you often need to measure the flow and etc. So you need to understand the basic theory behind this. Could I make myself clear to you about that? Hmm?
Yes, sir.
Now let's come to the point. The coronary artery atherosclerosis. We will not use the term atherosclerosis. We'll use the term occlusion or stenosis because it can happen by factors other than atherosclerosis, like a thrombus. But so we will use a general term like occlusion or stenosis. This is the vascular tree, and three main vessels are highlighted in yellow. One is left anterior descending, left circumflex. Both are actually comes from the left coronary artery and the right coronary artery itself. So RCA, LAD, LCX. So most common sites are basically these two. I mean, the first few centimeters of LAD and LCX. Okay, the areas pointed here. So if we look at the angiograms, do you see the stenotic parts here on the right side? On the left hand side, it's from a young healthy adult who doesn't have any problem. But on the right hand side, some unfortunate guy or woman, I don't know, somebody having stenosis at two places. Can anyone tell me at which arteries they have this stenosis? Look at the picture and tell me.
Sir, LAD and LCX.
Thank you. And we see that can you see my pointer?
Yes, sir.
See this black dot here.
Yes.
So what are these black dots? Can you tell me?
Atherosclerosis. Block.
No. Thank you for trying.
Okay.
This is actually a branch. It's actually a
Sir,
curvature.
D1. Sir, D1 এটা.
Exactly. This is actually the vascular curvature that has been superimposed from the perspective it was looked at. It was being looked at. Okay, it's not an abnormality. It's a quirk of imaging, simply speaking. Okay, do you understand? Now, another thing you should notice that do you see this corkscrew-like vascular ends, like they're like some spiraling out of the vessels at this point? You see this?
Yes, sir.
It also presents somewhat here. What does this indicate?
Collaterals.
Collateral networks. These are denoted by these structures. Why they are like that? Well, because you know the heart has not, I mean, grown considerably, but the vasculature have. If you try to stuff a lot of, suppose you have got a string, and you have to put the string in a very small box, what will happen? Anyone? Suppose you have got a string that is quite elastic, like a telephone cord or something. So
Compressed.
And it will get coiled. Okay.
Coiled.
So new vascular networks have been developed to It's a actually consequence of chronic vascular occlusion. If the vessel is occluded for a long while, new blood vessels try to develop. Why? What is the signal there? Can anyone tell me?
Because there may be a blockage in the main arteries, so
Yes.
collateral is developed.
So what is the step behind the blockage in chronic occlusion in some supplying main branch, thoracic branch or something, and there are some steps. Those are the gaps, and at the end point is this development of collateral networks. Looks like this screws, cork screws appearance. So what is the intermediate steps? What would fill in the gaps? The starting point is stenosis, end point is collateral. What's the intermediate step? Anyone? You understand my question? Huh?
Yes, sir.
Yes, sir.
Okay. So can anyone tell me what is the intermediate step? How does the tissue know that it has to grow new blood vessels there? Well, the answer is very simple.
Perfusion, reperfusion injury.
Thank you for replying, but not perfusion injury because we're not talking about establishment of perfusion. Here, the key word is hypoxia. Okay, hypoxia triggers new blood vessel formation. Okay, if the hypoxia is not too damaging, it will not immediately, cause heart attack or something, but in time, it will create some collaterals. But unfortunately, the coronary collaterals are not adaptive in long term. They cannot compensate for the workload of the heart in the long term. But well, surely they do try to compensate for that. But in long term, the collaterals fail. The trigger is hypoxia. Do you get the point? Huh?
Yes, sir.
And here is this person unfortunately died, and this was his or her heart. And can you see there is something here within the yellow circle? Can you see that? Can anyone tell me what is this? This
Necrosis.
no, this is a thrombus. Okay.
Clot, thrombus, yes.
Yes, this is a thrombus, and this thing was looking like this when the angiogram was done. Okay. Oh, sorry. This one is the circumflex artery, not yeah. So this one was looking like this. Okay. Do you see that now? Huh?
Yes, sir.
Yes, sir.
Okay. Now, when does stable angina becomes unstable angina? Firstly, can anyone tell me the difference between stable and unstable angina? Anyone?
So যখন স্যার প্লাকটা মানে আর্টারি থেকে ছুটে যাবে তখন
Just think about the clinical features. Just a patient has come. You do not know.
ওকে স্টেবলে স্যার হচ্ছে রেস্ট করলে স্যার পেইনটা ডিসঅ্যাপিয়ার হয়ে যায়, আনস্টেবল রেস্টেও ডিসঅ্যাপিয়ার হয় না।
Okay. Yes, that is one point. And another thing is, unstable angina can at any time randomly and progressively it becomes more and more severe. Okay. It
Yes, sir.
becomes more and more severe. Like if you have an old laptop or mobile phone, it becomes increasingly slower and slower and slower and slower. If you restart it, it will take a long time, and progressively becomes much slower that you have to replace that device. It's something like that, unstable angina. But stable angina is not like that. Stable angina is like a phone or device or something, maybe iPhones, I don't know, I'm not advertising for iPhones. I do not use iPhones, but the iPhones are a bit slow too, but they remain stable over a long period of time. Okay, Androids are unstable angina. They get progressively worse. Anyone agree or disagree with me?
Agree, sir.
Okay. The thing is that what is the thing that causes stable angina to become unstable angina or acute MI or sudden cardiac death? What is the most common thing to cause this? It's acute plaque change. Okay, this is the most common cause that converts stable to some unstable thing, angina or acute MI. Now, this acute plaque change, it can be rupture, erosion, ulceration, fissuring, hemorrhage, etc. Anything that can be caused to an atheromatous plaque. Okay, if there is a stable occlusion, I've told you that I've already mentioned that this atherosclerotic plaque can remain stable for a long period of time because it changes very slowly and it gives the body the coronary vasculature to time to adapt, because it does not usually change very abruptly unless there is acute plaque change. Otherwise, it grows very slowly, and the body has a lot of time to adapt to that change. It creates collaterals. It redistributes her workload. Can adapt in a number of ways. So stable angina remains stable because the atherosclerotic plaque, if it's caused by an atherosclerotic plaque, it remains stable. But if please keep in mind that angina can also come from, I mean, thrombus without any atherosclerotic plaque. That can also happen. But here in this case, we are talking about atherosclerotic plaque associated angina. Now, if this plaque somehow disrupted suddenly due to any kind of factors, so then it becomes dangerous instantaneously, just like that, in a matter of minutes. Do you understand the point?
Yes, sir.
Now, the pathophysiological spectrum of ischemic heart diseases, we have already talked about this. In stable angina, the stenosis is fixed and there is no plaque disruption. So this is induced by exertion. I mean, when the heart cannot pump to a capacity to meet the demand of someone who is exhausted or exercising or something, so then there is chest pain. Otherwise, everything is okay because the occlusion is fixed. It only feels pain or only feels like uh, angina symptoms when that particular capacity is strained. Otherwise, nothing. The person feels nothing wrong actually. Now, the unstable angina, it's suddenly some transient reduction in coronary blood flow, and there could be some infarct, maybe no infarct. So in unstable angina, you may or may not have ECG changes. In stable angina, at rest, you take ECG, you do not see much of a change. In unstable angina, there could be some microinfarct, and that may cause some ECG changes, but in other times, it may be completely normal on ECG. So these increasingly frequent, prolonged, or severe symptoms associated with it. And then comes acute MI, which is a major reduction in coronary blood flow, and there is often macroscopic infarct. If you could look at a heart, somebody died of acute MI and do an autopsy, then the infarct is often visible in the naked eye. Don't even need microscope to see that. So it's sudden, severe, and not relieved by rest. And then comes the sudden cardiac death. Uh, So it's regional myocardial ischemia, and usually the sudden cardiac death is caused not directly by the ischemia, but due to but due to the fact that the regional myocardial ischemia, only a part of the myocardium is ischemic, then it causes fatal ventricular arrhythmia. This is the common mechanism for a person to die of sudden cardiac death. It may or may not have symptoms, and if there are symptoms, the death is within 1 to 24 hours of the onset by definition. So what is the chance of death, percentage of death in case of sudden cardiac death? Is it 100% or less than 100%? Can anyone tell me? Anyone? What is the death rate in sudden cardiac death? If someone has sudden cardiac death, then what is the chance of dying due to sudden cardiac death? Can anyone tell me?
100%.
Thank you.
Sudden.
Thank you for your input, because we all learn from our mistakes. Sudden cardiac death has not a 100% mortality. Can anyone think of any other any explanation here? Well, it's pretty high, but it's not 100%. Can anyone think a cause of this kind of statistics? Anyone?
So this sudden death, why it is not 100%?
Well, thank you for asking the question. The thing is that the sudden cardiac death means if you have no cardiovascular, death within 24 hours, it means that there are differences in criteria in sudden cardiac death. Some experts believe that if the person does not ultimately die of sudden cardiac death, it is not sudden cardiac death. So the definition ensures that patient dies. Okay, but there are other experts who say that no, the sudden cardiac death is to be considered if someone has got no vital cardiovascular signs. Okay, there is no ECG, no pulse, no pressure, nothing for a certain amount of time. And if the resuscitation team succeeds to bring back the patient, then the patient would have been diagnosed that had a sudden cardiac death, but then resuscitated. Okay, do I get my point?
Yes, sir.
So there are the point of bringing this up is that there are differences in opinion. What is death in case of sudden cardiac death? Some consider that if resuscitation was successful, then it was not sudden cardiac death. Some other experts say no. Sudden cardiac death means there is no cardiovascular feature of living. So the person is technically dead due to in terms of cardiovascular parameters. But if that person is immediately resuscitated, then the person will be diagnosed as having sudden cardiac death yet survived. So these variations in definitions make the percentage of dying of sudden cardiac death less than 100%. So if you go through the Google's, published articles, you'll find these interesting things, that the percentage of deaths from sudden cardiac death is less than 100%. Of course, it's very high, but less than 100% in some studies, because they used a different definition. So do I get my point? Do you get my point? Huh?
Yes, sir.
Okay, thank you. Now, this fringe metal angina. This is Myron fringe metal, and this angina is named after him. It's a special category. That's why I really didn't include it in this spectrum, because it's a category of its own. It's rare. It's caused by coronary artery spasm. It's unrelated to physical activity, heart rate, blood pressure. Actually, these are not the risk factors for fringe metal angina. High blood pressure, low blood pressure, heart rate, these are not risk factors for this. This occurs independently, can occur at rest. Okay, and it generally responds promptly to vasodilators, like if you give nitric oxide or nitroglycerin, whatever. So patient will respond quite well, and it's occasionally fatal. Not death rate is not very high. I do not remember what percentage death from fringe metal angina. It's not very high. If someone has got other ischemic heart disease complicated by fringe metal angina, then that's a matter of headache. Otherwise, on its own, it could kill people, but it's rare, and we might not be too much worried about it. So, do I get my point? Could I get my point understandable to you? Huh? About this one?
Yes, sir.
Okay. So, whenever evaluating this, sometimes the equations will not. I mean, things will seem weird, and something doesn't quite fit. It may happen rarely, but it can happen. Then you may have to think about what about differential diagnosis of fringe metal angina. And do you know what a zebra is? Anyone familiar with zebra? Can anyone tell me what is zebra is?
No,
Huh?
No, sir.
ZEBRA, zebra. Anyone seen any?
no, sir.
Nobody seen zebra. Uh, 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 well, zebra is actually an animal. Looks like
Oh, I
uh,
didn't get that question.
and it's like a horse, and it has got. You can tell that.
That's zebra. You seen it? Right? We didn't understand the term.
Okay,
We
okay,
have seen zebra.
okay. Thank you. I was trying to come up with a definition of zebra, like horse-like animal. Has got white stripes in the black background, or you could say that black stripe in white background, or something like that. So, the zebra is a term used in Harvard Medical School to denote denote a tendency of new medical students. Whenever they read something rare, they seem to find that diagnosis everywhere. Okay, new med students reading some rare symptom, rare syndrome or disease, and they start finding that rare condition within themselves, within all other patients, within everyone. Are you familiar with this type of tendency in your med school? I mean, MBBS school, huh? Medical college. So this fringe metal angina is one of those zebra diagnoses. So don't make it on the first glance. Okay.
Yes, sir.
Do I get my point? Huh?
Yes, sir.
Yes, sir.
Okay. Now, then comes the myocardial infarction or heart attack. So it's a death of cardiac muscle due to prolonged ischemia, and it depends on a lot of factors. So I have actually made a list of it. I don't intend to read the whole list here. It's intended. I prepared the list and pointed the keywords in slightly different shades of the line color, so that when you go through later, I'll share this PowerPoint presentation. So if when you go through later, you can easily, I mean, get the point or have some try to remember it well. So it's color coded here. So you already know that the location, severity, and rate of development, etc. Other vascular collateralization, etc., etc. So I think you can skip this slide, but it's important. Please do read it when you get the time. The thing is, the development of myocardial infarction, it follows a quite interesting pattern. Do you see that? Suppose there is acute coronary arterial occlusion. My mouse pointer is visible, right? Pointer, is it visible? Yeah?
Yes, sir.
Okay. So here you see that arterial occlusion. Maybe this is thrombus. I don't know. Maybe this is thrombus, and this occlusion is eventually causing this infarct, which is denoted by this pale area here. See. Now, what does this pale and if you take a section, I mean, if you take a section from this tissue, then what will it look like? So this is the obstructed coronary artery, and this is the area that is supplied by it. Now, the area most adjacent to the artery, it will still get some supply of oxygen and nutrients, okay, of oxygen. But the zone of necrosis or cell death, myocardial death, will start to begin from the distal end of that section, and eventually it will go towards the pericardial surface. So the pattern is, if some vessel is occluded or supply is diminished at some vessel, myocardial vessel, the uh, blood supply, the supply will ham, uh, will cause the reduced blood supply will cause ischemia from distal to the vessel to proximal to the vessel. Do you get the point here? It's important because it's related to how the ECG is read and interpreted. This pattern is important to keep in mind. Do you understand this pattern? Yes. The
Yes,
zone
sir.
of necrosis, the progression, the direction of progression, the origin of progression. The pattern is from endocardium to pericardium, not the other way around. Okay? Do you get the point?
Yes,
Huh?
sir.
Okay. Now, there are different ways it can happen. The full thickness or transmural infarcts may be there, and depending on which wall is affected or which vessel is affected, the I mean the chest leads and in the 12 leads and also the limb leads, the 12 leads ECG will show different types of patterns involving different leads. So I will not teach about the ECG here. That's a job of cardiologist or maybe the internal medicine specialist. I'm not going through that. I'm just going to the pathological aspect of it. But if the reperfusion, I mean restoration of the flow, if it can be done, then this infarct might halt or stop before reaching the full thickness. In that case, you will get some infarct adjacent to the endocardial surface, and the part adjacent to the pericardial surface or the pericardial portion of the myocardium, uh, this will be spared. Okay, so this type of MI is sometimes called. Can anyone complete the sentence? This type of MI is sometimes called what? Dash MI in clinical terms. Anyone? Can you hear me?
Subendocardial.
Exactly, subendocardial MI. So the key ECG difference is that these are non-ST elevation MI. Okay, NST MI. Please do remember this. Okay, and these are STEMI, that is ST elevation MI. I'd love. ECG is one of the favorite things in electrophysiology, but this class does not cover it. So I regret to skip the ECG findings here. But do remember this pathology. Now, uh, here is a timeline of how things get worse. Okay. Now, at the very beginning, I mean, within seconds of myocardial ischemia, in case of myocardial ischemic diseases, I mean, in seconds, uh, the ATP starts to fall. And in less than 2 minutes, the contractility is lost. The affected muscle can no longer contract. And in 10 minutes, you see that ATP, there's a 50% fall in ATP if the not within the cell, if it's within the affected myocardium. If it's 100% ATP is normal, then you will find 50% ATP within the cell. And between 20 to 40 minutes, the cell injury becomes irreversible. We talked about irreversible cell injury, right? So what happens here? Can anyone tell me? So within 20 to 30 minutes, I mean within half an hour, the cell injury will become irreversible. So what constitutes a cell injury to be irreversible? When is it irreversible? Can anyone tell me? Please.
So loss of ATP microscopic.
Loss of ATP is there, but there are two main key factors that separates reversible from irreversible injury. What are those? I mean, irreversible means you cannot bring the cell back. It's gone.
So loss of lysosomal enzyme.
Well, that's a sub point, but the main 2 points, mitochondrial damage. Mitochondria, if mitochondria fails, who will produce the ATP? Cytoplasm, it cannot make that much. Okay. And the other thing is the rupture of membranes. The plasma membrane may rupture, or the subcellular membranes, like the mitochondrial membrane may rupture, the endoplasmic membrane may rupture. All these things, the lysosomal membrane may rupture. So the membrane rupture, if the membrane gets ruptured and the mitochondria fails, then we call it irreversible cell injury. You cannot bring that cell back if these two things happen. Okay. Do you remember this now?
Yes, sir.
It's okay to forget things. Usually, after a typical lecture, it's considered a success if students remember more than 10% of it. Okay. So, thank you for forgetting some of it. Now, at 40 minutes, there is 90% fall in ATP. So, by that time, there's pretty much nothing to do about that particular cell, but we try to salvage the cells that are still not at irreversible stage of the injury. Okay. And after about 1 hour, you'll see microvascular injury. Okay, and that list goes on. The thing is that the ATP falls and the lactate rises. So where does this lactate come from? And sometimes you will see lactate dehydrogenase (LDH) measurement is done. Where does it come from? Anyone? Anaerobic glycolysis, does it ring a bell?
Yes, sir.
Okay. So since the myocardium is now struggling to generate ATP, it cannot use the mitochondria because it's damaged. So it's doing all it can do by using anaerobic glycolysis. It's not getting oxygen, its mitochondria is not working. So what can it do? It can like try to make some ATP at least through anaerobic glycolysis that will create lactate and that will upregulate the lactate dehydrogenase, which we get in blood. Okay, after the cell ruptures, it comes to blood. Now, do you get the idea of the mechanism here? Huh? Okay. Now let's look at some pictures. I think it will be fun because I don't know, it's fun for me, may not be for you. And it's day 1 after myocardial infarction. This is photomicrograph, and we're looking at about 400 times magnification. These are wavy fibers. There are some wavy fibers. Some of them have still got nucleus within them, like these. And sorry, some of it has lost its nuclei. So what kind of necrosis is this and why? Can anyone tell me? We talked about this in the previous lecture.
Coagulative.
Coagulative. Why coagulative? It's all right. You can make mistakes. No problem. Nobody can see you here. It's even easier to make mistakes here in online class. You know. Anyone, please. Okay, I understand. People, you do recognize each other's voices, but don't be afraid to make mistakes. Try. Why is it coagulative? Okay.
স্ট্রাকচারটা স্যার এখানে মেইনটেইন হচ্ছে।
Exactly. Maintains the original
জি,
structure. The
অরিজিনাল স্ট্রাকচার।
and
আর এই ফাইবার গুলো মানে
so this particular fiber is dying, but
die.
it's not completely dead. It has got nucleus
Yes.
within it. Okay,
জি স্যার
but this fiber and this has become eosinophilic, more pink, wavy, but no nucleus within. So it's wavy fibers. It's other way of saying that coagulative necrosis of. If you say that wavy fibers in pathology in myocardium, it means that it's coagulative necrosis of the myocardium, myocardial cell. Okay, and here is a normal myocardium, and you can see that the nucleus is in there, and there is bending pattern, normal, etc. And there is edema and neutrophils within the uh, necrosis. So necrosis has some inflammation within it. So that's what we are seeing here. Now, you see hemorrhage, the red things, the small structure, this is RBCs, and the contraction contraction bands. The contraction bands are also indicator of necrosis. It's seen in this yellow band, yeah, sorry, not yellow, the pink band-like things randomly distributed here and there, cross-sectionally. So these things are called contraction bands, and in reperfusion injury, similar thing may happen. This is a day 2 picture, but it can happen in day 1 if there was reperfusion and the reperfusion caused some reperfusion injury. This can also happen in day 1, but it's from a patient who died on day 2. And this is day 3 to 4. There are many more inflammatory cells here and there, and much more dead muscle cell fibers. The muscle cell fibers are no longer wavy. They became straightened due to the osmotic pressure around them. There are a lot of fluid there, so it's no longer wavy. The removal of necrotic myocytes will, the phagocytes will come into the scene. They are janitors. Do you know what janitor is? Anyone? Janitor?
No, sir.
Well, janitor is a term, is a, I mean, another term for sweeper. Okay, they clean up the mess. So the phagocytes come and they eat up the necrotic debris and dead cells and everything. They eat everything up. This happens in within day 7 to 10 from the onset of MI. Now, uh, at about 2 weeks, there will be some collagen. The stain is different in this case. You see, there's some blue things here. These kind of blue things were not visible because the histological stain, the color is different color is used. Staining used here. The new tissue, granulation tissue is forming. It will create some collagen patch. I mean, connective tissue patch. It will not have the contractile property, but it's some kind of scar. Okay. Now, this scar, you see these blue fiber-like things. These are the collagens that are being newly deposited, and these are the new blood vessels. You can see the red things, red groups of things. These are new blood vessels. They have got RBC within them. So these are capillaries. So granulation tissue is being formed, 10 to 14 days. And after 2 months, there is dense collagen. That same blue things now has increased a lot. Do you see that here? And some muscle fibers that survived somehow are trapped in between them. These muscle fibers are not very efficient to contract because they're trapped within this fibrosis. Do you see these blue areas here? These are dense collagen. See? Do you see that? Okay. And this was about 10 to 14 days. These blue things, I mean, the collagens are newly distributed. There are very few of them, but after 2 months, they occupy almost all of the infarcted area. Okay. Now we're talking about the reperfusion injury, and the reperfusion injury is, how does the reperfusion is established? There are main 3 ways where reperfusion is established. Can anyone say?
Thrombolysis.
Yeah. Thrombolysis, angioplasty, and coronary artery bypass graft. These are the main three ways the reperfusion can be established, but this reperfusion will cause a reperfusion injury. So you see, if there was no reperfusion injury, then this dotted line here, you see my mouse pointer here? See?
जी
Yes,
sir.
sir.
Okay. So, so at this point, the restoration was flow is, I mean, reperfusion is established at this arrowhead point. Now, if there was no reperfusion injury, the contractility or the function of the myocardium would remain at this point. I mean, the salvageable percent of the, this is the 100% myocardium. The myocardial ischemia or infarction, due to the infarction, we lost this percentage, maybe some 20-30% of myocardium here. The flow was restored here. If there was no reperfusion injury, there would be no additional myocardial death, and we will still get this percentage of cell still surviving. But due to reperfusion injury, these dotted lines will fall down a bit. It will come to this point. This is the some additional percentage we lose due to reperfusion injury, and it then usually becomes stabilized if taken care of. And so do you get this, that point of the graph? Anyone, any problem in understanding this part of the graph? Huh? Do you understand it? Is there any
Yes
problem?
sir.
Okay. So this percentage is lost due to mitochondrial dysfunction, monocyte hypercontracture, sorry, myocyte, not monocyte, myocyte hypercontracture, free radicals, leukocyte aggregation, platelet complement activation. All these things are caused by reperfusion injury. And this this portion of the muscle is lost due to that. But still, we should continue with reperfusion. Why? Because if we did not do any reperfusion, then the myocardium, the surviving myocardium will drop to almost zero. Okay, so this is the portion we could save by reperfusion. Although reperfusion did kill some of the myocytes, but still, if we did not do anything, this will go like this downwards. But since we did restore the flow, we could save this percentage of myocardium despite having some loss. So do you get the point here?
जी sir.
Okay. Now, the complications of myocardial infarction. Just take a quick look at these pictures. This is myocardial rupture. You can see here. This is rupture of the ventricular septum. This is complete rupture of the necrotic papillary muscles. See, the papillary muscle is detached. This section there. This is pericarditis, and this in particular is fibrinous pericarditis because fibrinous material has been deposited here. Now, this is a mural thrombus. Can anyone tell me what a mural thrombus is? Anyone?
Involving all the layers of
Of layers of? Okay, in a word, it's actually stuck with the wall. I mean, luminal wall of the cardiac chamber. Okay, that is mural. Mural means wall. Uh, are you familiar with the word mural? I mean, artwork, regarding artwork. Have you seen mural?
yes,
So the mural comes from the wall. The, the full term is mural artwork, but it's abbreviated to just mural. So mural means wall. The wall, a thrombus that's stuck with the wall, that's mural thrombus.
Luminal.
Now, it can also be attached to the valves as well, but that's vegetation. That's related, more related to vegetation. We'll not go complicate things there. Just wall thrombus. Now, and the early expansion of uh, anteroapical infarct with wall thinning. See, the wall is very thin here. This can also happen as a complication of a myocardial infarction. If this thinning continues, then what could happen? It becomes more and more.
Rupture.
Exactly. Thank you. So complications of myocardial infarction also includes, I mean, sometimes the thinning stops, but it leaves a large dilated area, I mean, ventricular aneurysm. So there are other things that do not have picture, which are contractile dysfunction. These are already shown to you. These 4 types of complications. I've found the picture to show you, but I couldn't find picture to show you these. This is a contractile dysfunction, arrhythmias, uh, capillary muscle dysfunction, right ventricular infarction, chamber dilatation. Chamber dilatation is its own separate category. Don't confuse it with aneurysm. I just showed. That's a different category. Without wall thinning, really thinning the wall, the chamber can dilate. We'll look at it later. And the progressive heart failure is also a complication of myocardial infarction. So, if there is post MI pericarditis or pericardial effusion, so this is a syndrome. Can anyone tell the name of it? Anyone? This is a patient having that syndrome. Can anyone name the name of the syndrome?
Pericarditis.
Yeah, this person has had that syndrome and died, and in the autopsy we got this picture. So what was the syndrome that the person was having post MI? Well, Dressler syndrome. Heard about it?
Yes, sir.
Now, that the sudden cardiac death, we already discussed about the definition. Different authors use different criteria, and the main cause is coronary artery disease, and can be the sudden cardiac death is unfortunately it can be the first manifestation of IHD. Okay, it's very unfortunate. I mean, have you heard the thing that he was perfectly well, didn't have any high blood pressure or anything, or perfectly healthy looking, no problem with him. One fine morning, he just died, or maybe died in sleep, or sometimes just fell down and died. Have you heard stories like this?
Yes, sir. So many.
Yeah. So these people, there is a differential diagnosis to that story. One of the reasons they could have died is a sudden cardiac death. It might not have any prior signs or symptoms. The first presentation could be this sudden cardiac death. Okay. So this has to be kept in mind. Now, why does it happen? Because there is a fixed critical stenosis. The stenosis has been developing for a long period of time. But that particular moment, that particular morning, that particular time, at that particular time, the ischemia just happened to cross a particular limit and kill that person. It can happen. Do you understand the point here? Okay. Huh? And acute plaque disruption, which we discussed previously, this is not that much common. It can happen without acute plaque disruption. Only 10 to 20% cases show acute plaque disruption. So sudden cardiac death may happen from a stable plaque. This is a very scary thing. Don't you agree? Huh? Do you get the point? I mean, what is to be afraid of here? Do you get the point that plaque disruption,
Yes.
without plaque disruption, can happen? Okay, most of the cases. So, but interestingly, 80 to 90% of patients who suffer from sudden cardiac death but are successfully resuscitated. Remember, I said that. So successfully resuscitated, they do not show any enzymatic or ECG evidence of myocardial necrosis. This is really an interesting thing that someone had sudden cardiac death, was resuscitated, but if the resuscitation is successful, it most cases it fails, but that doesn't mean we shouldn't try. We should try. In those patients who are actually resuscitated from sudden cardiac death, almost 90% of them do not show any changes related to myocardial necrosis. That's a fantastic finding. Don't you agree? Huh? So, do you understand the point and get the thing I'm trying to deliver?
Yes,
Huh?
sir.
Sir.
Well, don't worry. We're about at the end part of it. We started late, so it will take a little bit of time, but we're nearly to the end of it. It's really a big topic. I'm not trying to bore you. Okay, I'm really sorry if I did that. Now, the sudden cardiac death in younger victims, the non-atherosclerotic causes are more common. Please do remember that. Why in younger victims of sudden cardiac death, non-atherosclerotic causes are more common? Can anybody tell me? Anyone? I've already told you the reason previously within this lecture, but as an answer to a different question.
So atherosclerosis takes time.
Exactly. This is a mantra. You can keep it in your mind. Atherosclerosis takes time. Still accidents can happen. Why? Acute plaque change. Okay. Now, these are the list. I'm not going to go through the list, but these are actually the non-atherosclerotic causes. Doesn't happen in adult victims, maybe those who are 50, 55, or 60 years or more. You do not see these causes there if they have SCD, but in younger age group, like in the 20s, 30s, these patients can have these causes more commonly than atherosclerotic causes. Now, chronic ischemic heart disease is also known as ischemic cardiomyopathy. Usually, this is the more frequently used clinical term, ischemic cardiomyopathy. Chronic ischemic heart disease is a term that usually pathologists use. Okay, clinicians prefer the term ischemic cardiomyopathy. It's a progressive congestive heart failure, and why does it happen? It's due to accumulated ischemic myocardial damage. So can anybody explain the term accumulated to me? Are you familiar with the term accumulate? What does it mean to be accumulated damage? Anyone?
No idea.
Okay, accumulated means it grows slowly. Slowly over time. It's like uh, at an individual. It means the sense it's trying to convey here that maybe you just Uh, do you remember? Did anybody have any piggy bank when they were little? Anybody had any piggy bank to, collect the pocket money or something like uh, uh, a clay or made out of clay? There's a slot you could put coins in or notes within there. When you get some tips from some adults or something, you could save it there. Did anyone have that? Are familiar with the concept? Anyone? Hmm? Anyone? I mean, if you can save, say maybe 10 taka every day and put it somewhere, then on its own, this 10 taka would not would be not that much. But you see, after 10 years, it will become a huge amount. Do you get the point?
Yes, sir.
Yeah. So that is what accumulated means here. There is tiny, small ischemic myocardial damage. Every damage that is accumulated each day is not that great. It's almost negligible. But if it gets accumulated, this type of damage continuously for a long, long period of time, years together, then it can have consequences. That is the accumulated ischemic myocardial damage, and or inadequate compensatory response. There are compensatory responses to chronic ischemia. One of them has been shown to you. Please name that. Anyone? Well, the compensatory response is One of the responses you've shown that collateral circulation establishment is one of them. And also some myocardial changes are also there. These, if they're inadequate, then also chronic ischemic heart disease can happen. And contributing factors are prior myocardial infarction, previous coronary arterial interventions, like those who have stenting or PCI or other procedures being done are higher risk of developing chronic ischemic heart disease, bypass surgery, those who have, and cardiac transplant patients. So the coronary artery disease can happen in several ways. It can directly cause myocardial ischemia, or without causing ischemia, but acute plaque change can happen, and this can lead to myocardial ischemia directly or through acute plaque change. And this may cause myocardial infarction and arrhythmias, and the story can end there. The person can suddenly die from myocardial ischemia or anything. But if that person survives, then these things can happen. In fact, healing, ventricular remodeling, which and hypertrophy, dilatation, viable muscle, etc. So these things can happen and may turn into chronic ischemic heart disease. And from that chronic ischemic heart disease, somebody can die suddenly. And if that person develops congestive heart failure, this can also lead to sudden cardiac death. So this is in summary what we have discussed so far. Now there is another topic left. I'll try to be as quick as possible about this. This is hypertension. You all know that normotensive is regarded when at rest there is less than 120 by 80 millimeter of mercury. Hypertensive is mostly regarded when it's above 140 by 90, and malignant hypertension is regarded when it's 200 by 120 for, I mean, at least it continues regularly, persistently for about a year or two or even more. So in this case, it's called malignant because this can kill the person instantaneously, anytime. So, and the main mechanisms for blood pressure regulation are shown below. There are many things. All these things are encountered in physiology. Please get a look at it again. I'll not discuss it further here. And this is a very important mechanism, which is renin, angiotensin, aldosterone, and atrial natriuretic peptide. And so, are you familiar with the brain natriuretic peptide? Anyone? Brain natriuretic peptide? Anyone?
Yes, sir.
Yes, sir.
Where does it come from?
Right atrium.
Brain natriuretic peptide. Atrial natriuretic peptide comes from atrium. Okay, that's what it's named atrial. But what about brain natriuretic peptide? It's also important, but not shown in this figure.
Left heart failure about it.
Yeah. Brain natriuretic peptide is first identified to be secreted from brain, maybe from rodent or mouse brain, but later in humans it's found that mostly it's secreted by ventricles, okay, ventricular muscles under stress. So later the term BNP, brain natriuretic peptide, is retained, but the elaboration of B was changed. It's now called B-type natriuretic peptide. It's still BNP, but the B is no longer brain. It's B-type natriuretic peptide, and ANP is A-type natriuretic peptide. Okay, ANP. So this is an update. I think I should have informed you. Okay. Now this renin-angiotensin mechanism, you all know about it. How if the blood pressure is perceived to be low within the kidney, it activates the system, and the vasoconstriction is there, water and salt retention is there, and the blood pressure rises to a point which turns off this feedback mechanism, and the blood pressure remains stable. So this is in summary the renin-angiotensin system. So it normally helps maintain the blood pressure to a normal level, but when there is some problem within it, because you know renal perfusion can reduce due to different causes other than actually there is a systemic hypotension. Can anyone tell me that how the renal perfusion can reduce without having really a systemic hypotension? There is no systemic hypotension, but kidney is thinking the blood pressure or volume is low. How can that happen? Anyone? Can anyone tell me that how can it happen that blood pressure or volume is not low, but the kidney is thinking that it is low, and that's why it triggered this mechanism? How can this happen?
Renal artery stenosis.
Yes, this is one of the reason. But also, if there is heart failure, I mean, if there is left heart failure, the systemic perfusion is reduced due to the reduced pumping of the heart. So this will also make the kidney sensors to think that maybe I should upregulate this renin-angiotensin system, and it will put more pressure on heart and ultimately causing more failure. Okay, this is
Yes.
a vicious loop. Do you understand the point? So, well, this is something that natural selection could not account for, because when we lived in woods and caves, we didn't have to worry much about this hypertension. So the kidney never get to face an environment where it could be fooled like this. Our modern lifestyle is fooling the kidney to think in heart failure patient that it needs to raise the blood pressure. So this is the root cause, one of the root causes of this kind of vicious cycle. And by controlling this angiotensin path axis, renin-angiotensin axis, we can have good outcomes, including beneficial remodeling of the heart. So, what group of drugs do you use to achieve that goal? Anyone? Okay, it's ACE inhibitors or angiotensin receptor blockers. Those are some drug of choice nowadays in most cases of hypertension, if there is no other contraindication. Now, the systemic hypertension is essential hypertension, accounts for 90 to 95% cases. Secondary hypertension is about 5 to 10% cases. And there are some secondary causes. Not all causes are listed here. If hypertension and systemic hypertension can have its own 2-hour lecture, I'm not going to go with that. Just a few of the causes are listed here, and not all categories are also here. This is a very, very incomplete list. There are pulmonary hypertension, and WHO classification has got 5 groups about it. I like to explain that, but there is not much time, so I'm going to skip that. Please read these 5 groups classified by WHO, and it has got something to do with how you image it. So please pay attention to these 5 categories. You guys are partially in charge of determining which group it is, and the treatment will follow accordingly. But mean pulmonary arterial pressure is greater than or equal to 25 millimeter mercury at rest to qualify for to consider it as pulmonary hypertension. Now you can categorize these in 5 WHO groups. And pulmonary hypertension has got a slightly different mechanism, molecular mechanism, than systemic hypertension. And essential hypertension is essentially mostly unknown, although it has got some genetic familial backgrounds, but we do not fully know most of the cases of the hypertension in systemic circulation. But in pulmonary hypertension, the molecular markers have been identified, like BMPR2 locus. There is mutation. And also there are some other modifier genes and environmental triggers all together causes pulmonary vasculature to thicken and get occluded. This is one of the main reasons of primary pulmonary hypertension. This is the essential hypertension of the pulmonary circulation. So essential hypertension of the systemic circulation is there. Also, we have got the counterpart in pulmonary hypertension, which is known as primary pulmonary hypertension, and it mostly comes from the interaction of the gene and environment. We do not find a triggering factor within the physiological diagrams we draw. It doesn't appear there. It has to be considered separately, like the essential hypertension, this primary pulmonary hypertension. And here are some microscopic pictures. You can see if a blood vessel is subject to hypertension for a really, really long time, we see this higher line atherosclerosis. It kind of looks like the fibrinoid necrosis we saw in our previous lecture. The blood vessel wall is pink and hyalinized, homogeneously pink. No layering is visible here. Just looks like a pink donut here. Have you had some pink donuts lately? I don't know. It looks like that. Now, this is from and this is from kidney, and this is hyperplastic atherosclerosis, where you can see it looks like this is glomeruli. We're not talking about this. The arrow marks at this vessel here. So you see the hyperplastic atherosclerosis. This is also an evidence of hypertension, long-standing hypertension in kidney. And you see this onion skin type appearance, like it's multi-layered. It's like a section from an onion. So this type of thing can happen in hypertensive patients. We get renal biopsy and we can see this kind of structures there. And now hypertensive heart disease is can be, I mean, systemic or left-sided or pulmonary or right-sided. You already told that. And right-sided heart failure has got another name, which is called cor pulmonale. And this hypertension, hypertensive heart disease ultimately causes pressure overload and ventricular hypertrophy. Now, the minimal pathologic diagnostic criteria for systemic heart disease, systemic hypertensive heart disease or HHD, is the left ventricular hypertrophy, usually concentric, and hypertension. Hypertrophy and hypertension has to both be included to diagnose this thing. If one of them exists, the other one does not, then it does not qualify as systemic heart disease. So this is usually reversible up to a certain extent. The hypertension is controlled. The systemic hypertensive heart disease is also reversed. So controlling the hypertension is really important because it's achievable. Now, depending on the severity, duration, and underlying causes of hypertension and adequacy of therapy, hypertensive patients can enjoy normal longevity. I mean, just like the normal population does not have hypertension, and the people who have hypertension but managed adequately, they can have a full life. But if they develop this ischemic heart disease, things could go south. So they can suffer coronary atherosclerosis and muscle hypertrophy, heart failure could be there. Sudden cardiac death is, of course, a scary outcome of this. And in the meantime, the person might suffer renal damage and stroke, all these things. But hypertension, hypertensive heart disease, if managed adequately, can give a person a full life. Oh, I'm sorry, so time is almost up. So give me a two more minutes. I think 2 more minutes. I can wrap it up. Thank you. Thank you for reminding. So these are the disorders predisposing to cor pulmonale, the diseases of pulmonary parenchyma. There are 4 disorders that predispose to these 4 groups of diseases that predispose to cor pulmonale, which is the disease of pulmonary parenchyma, pulmonary vessels, affecting chest movement and pulmonary arterial constriction. A lot of causes are there, but remember these main 4 headings at least. And the patterns of cardiac hypertrophy, it can be due to pressure overload, due to volume overload. If it is due to pressure overload, then the sarcomeres are arranged in parallel pattern and causing the wall thickness to increase. And if it's volume overload, mostly in case of right-sided hypertrophic heart disease, we see heart failure also, that the sarcomeres are arranged back to back. It's called a series assembly. It doesn't cause the wall thickness to increase, but it causes a bigger chamber. So heart weight is a better indicator of hypertrophy than wall thickness, because in case of volume overload, you do not get wall thickness to increase, but overall mass cardiac weight is increased. There are radiological ways to measure that. You guys are going to do that in the future if the investigative technology comes here. And this is probably the last slide of it. And we see that in systemic hypertensive heart disease, the left ventricular hypertrophy and is concentric. The sarcomeres are arranged a multi-layered way, having the same center. I mean, wall thickness is increased. In case of right ventricular hypertrophy, dilated, this one is dilated, and This is due to the series arrangement of sarcomeres, and probably hypertensive heart disease. We see this right ventricle is dilated, but its wall thickness is not that much increased. So this is the basic pathologic difference in case of the two hypertensive heart diseases, two kinds of, and sometimes they do overlap. Please don't forget that. And okay, I'm concluding, but my last question to you, can anyone recognize this structure? Oh, it's written here, it's a pacemaker. Okay, thank you. And any question there? I'm sorry that I took a lot of your time, but the topic was really, really big. Hello?
The topic is so vast and so hard.
Okay, I think people, some of you are will go to prayer now, so I should conclude. But if anyone else who want to ask me question can ask. If not, I'll conclude it. Okay.
No questions, sir.
Thank you. No question means two things. That is you understand. I could make. I mean, you understood everything, or maybe I could not make you understand anything. And there is a third possibility. It's been too long to a lecture. There can be three causes. Thank you. Feel free to ask me by email.
Thank you, sir.
If there is any something I can
Yes, sir.
clarify about this lecture, and you will find the lecture and this PowerPoint via email. Thank you, everyone.
Thank you, sir. Thank you.
Thank you, sir.
Thank you, sir.